Would the contractor please then promote Nicolas Smit of the American Mass Manufacturers Association to panelist status?
Have been promoted.
All right, thank you. Mr. Smit, please state your name and your affiliation and make your presentation.
Hi, everyone. My name is Nicolas Smit. I'm the Executive Director of the American Mass Manufacturers Association. I also sit on the federal government's POAM task force working on President Biden's executive order to come up with PPE and PPE supply chain strategies for pandemics and biological threats. Plus, I also sit on the government's joint SCRWG task force.
Mr. Smit, may I ask you, this is being transcribed by a court reporter. Could you please speak a little bit more slowly?
Okay.
Thank you.
In 2019, 5,333 workers died on the job. In the first year of the pandemic, over 3,600 healthcare workers died from COVID. In addition to the thousands of healthcare workers that have died, hundreds of thousands have developed long-term disabilities due to long COVID. It has been decades since any industry has experienced this amount of deaths in such a short period of time, and the first time so many workers in the healthcare industry have died or been disabled. In workplaces with deadly airborne contaminants, workers typically have multiple layers of protection to ensure there's no possibility of exposure. When one thing fails to work, the additional layers of protection are there to keep the worker safe. A layered approach to safety is just what healthcare industry needs as well. We now have the tools needed to keep every healthcare worker properly protected from transmission. However, we are choosing not to use them. Denying healthcare workers proper masks has led to millions of infections and is the biggest reasons why healthcare has now become the most dangerous industry to work in. Thousands more healthcare workers have died in 1 year fighting COVID than soldiers died in the 20 years they were fighting the war in Afghanistan. The war on COVID is one hospitals can win, however, they will continue to lose their battles with COVID until healthcare workers are given the proper tools to protect themselves from such a deadly and debilitating workplace disease. Healthcare workers were originally kept in harm's way in 2020 due to the failure to acknowledge airborne transmission was occurring, not having enough N95s to keep all healthcare workers properly protected, and refusing to follow the CDC pandemic plans to put elastomeric respirators into widespread use. The failure to follow the CDC's pandemic plan to put elastomeric respirators into widespread use resulted in healthcare workers dangerously reusing N95s for weeks to months at a time and downgrading their protections to surgical masks. Most hospitals still don't know elastomeric respirators are safe, recommended, or that the CDC has been recommending them as superior alternatives to N95s for tuberculosis, SARS in 2003, H1N1 in 2009, and other deadly viruses since the mid-90s. They are available from dozens of manufacturers, are the most cost-effective option while offering the highest levels of protection, but healthcare workers are being told to use loose-fitting surgical masks instead. The importance of elastomeric respirators needs to be promoted so employers can know they are great options that can keep employees safe while keeping their PPE costs down. The CDC has said elastomeric respirators provide better source control than surgical masks, so why are surgical masks recommended for source control versus elastomerics? In January 2021, President Biden asked for new workplace protection so workers in every industry could be given proper masks and we could end workplace transmission. By preventing most workplace transmission, we can also stop a lot of the community transmission that comes from workplace outbreaks. In March 2021, OSHA updated their mask recommendations for workplace inspectors and told them that food plants, schools, labs, manufacturing facilities, and high-volume retail settings were now so high risk that inspectors were recommended to upgrade their protections from N95 disposables to reusable elastomeric respirators with N95 or P100 level filters. Workplace inspectors ended up getting better masks than healthcare workers treating COVID patients, while the workers in these high-risk workplaces continued to use cloth masks. On April 9th, 2021, the government declared the N95 shortage over, and the FDA announced that hospitals needed to stop reusing N95s. The FDA told hospitals to transition healthcare workers to elastomeric respirators if not enough N95s were available. Hospitals, however, continued to force healthcare workers to reuse N95s since most hadn't learned about the N95 supply announcement or the new rules on N95 reuse until more than 6 months after they were announced. Since important new recommendations are rarely promoted beyond federal agencies quietly updating their websites, they are rarely followed or become well known even among other government agencies. In May 2021, the CDC finally acknowledged airborne transmission was occurring. This was the opportunity to fix the wrongs of ignoring to use a precautionary principle from the start. However, instead of improving safety, the government told everyone they no longer needed masks because vaccines did such a good job preventing transmission that they made masks redundant. In June 2021, there was enough N95s and elastomeric respirators to keep every healthcare worker in the country protected from transmission. Despite knowing healthcare workers needed better masks to protect them from airborne transmission, the government decided to only protect healthcare workers with airborne protection when they were around known COVID patients. And when they weren't around known COVID patients, they were recommending droplet protections. N95s and elastomeric respirators also provide better droplet protections than surgical masks. So if droplet transmission is what is believed to have occurred, they would also provide better protection while also providing airborne protection. The June ETS did not bring the mask protections workers in other industries were promised they would have, and because of this, workplace transmission has continued to be common instead of rare. Since the current approach is to allow infections to occur and to try and treat the fallout of these infections versus trying to prevent as many infections as possible, healthcare workers have continued to be exposed to more infectious patients and coworkers each wave instead of less. In July of 2021, the CDC explained they had learned vaccines could no longer prevent transmission and that masks were again needed. However, despite this pivotal discovery, the government never introduced the mask protections workers were originally supposed to receive, despite OSHA saying they were in grave danger. A lot of workers lost their jobs for not getting vaccinated to help stop transmission. Most workers want to do their part to stop the cycle of transmission, which is why we must ensure we give them the proper tools to do so, including vaccines, proper PPE, proper ventilation, social distancing, and more. In late December 2021, as Omicron was breaking records from cases, hospitalizations, and deaths, hospitals rationed COVID ICUs to one N95 per shift. Infections among healthcare workers had become so widespread in December that instead of attempting to limit the spread, workers were told they had to work while infectious. This year, new reasons not to give healthcare workers proper masks are being used. The reason is no longer short supply. There are so many N95s available that domestic manufacturers are closing in record numbers due to the lack of demand for the hundreds of millions of N95s they have. The reason is no longer due to the vaccine being good at stopping infections. Almost all healthcare workers are fully vaccinated and boosted, yet healthcare worker infections remain common. The reason is no longer that we believe the virus is only spread through droplets. The White House and CDC have long said airborne transmission is common and that the virus could even stay suspended in the air for hours, plus infect somebody that was never in the same room as the infected individual. Healthcare workers are now being told they don't need to be upgraded to airborne PPE because their risk is low and employers don't feel like they should be forced to reduce the risk further. They're told that if they do get infected, healthcare workers can take antivirals like Paxlovid to keep them safe. This completely ignores long COVID and that there aren't enough antivirals for every worker who gets infected. Miners are not told they don't need a hard hat because the probability of a rock landing on their head underground is low. So why are we allowing workers in the healthcare industry to die in the thousands and be disabled in the millions while saying their risk is low? Why is it acceptable to keep those workers at risk despite having the tools available to virtually eliminate it? The damage done by allowing healthcare workers to get infected also extends to patients. Hospitals keep closing departments and canceling life-saving procedures because too many staff are infected. Hospital-acquired infections have also killed thousands of patients. It was recently discovered that Paxlovid can lead to rebound infections where people that stop testing positive start to test positive 5 days after the antiviral treatment and develop symptoms once the treatment is complete. Workers are going to believe they are no longer positive and will go back to work while infectious because of this rebound effect. This will create additional outbreaks unless we pair antivirals with proper masks and ensure the public is well aware of this rebound effect. To keep workers safe, we need to update the definition of close contact to include fleeting exposure. In June 2021, the Australian government discovered that it could take just seconds to infect someone after an individual infected many others just by walking by them in a busy shopping center. In July 2021, the CDC explained that Delta had made COVID one of the most easily transmissible viruses known to them. If someone can be infected within seconds or be infected by someone that was never in the same room as them, this completely changes the definition of close contact and what exposed individuals need to do. If too many healthcare workers get long COVID and become unable to work, who's going to take care of patients? The healthcare system is already at a breaking point. We can either keep healthcare workers at risk and let it get worse, or give healthcare workers all the tools they need to stay safe so we can start to repair the damage that has already been done. The time to act to keep healthcare workers safe is now. It is already too late for the thousands of healthcare workers that have died, but it's not too late to protect all the ones that keep putting their lives at risk in order to take care of us in our greatest time of need. Thank you.
Thank you, Mr. Smit. Are there any questions for this witness from OSHA?
Yes, thank you, Your Honor. This is David O'Connor with OSHA. Mr. Smit, could you clarify when you believe it would be appropriate for OSHA to require respiratory protection in healthcare settings? Do you have a view on that?
Yeah, every part of the hospital is going to be a place that's in danger, especially if patients are still told to use surgical masks. So when you first walk into a hospital and if you're infectious and you have to take off whatever mask you have on, you can then have that virus remain suspended in the air. So everybody walking into the hospital entrance after that person, unless there's air exchanges, can infect the people exchanging their mask or wearing a surgical mask with the gaps on the side. So everybody in the hospital could be given proper protection, or respirators instead of masks, sorry.
Okay, thank you. And with regard to the type of respiratory protection, do you look at elastomerics and view them as an alternative to N95s in certain circumstances, only when there are N95 shortages, or would they be appropriate in other circumstances as well?
They're appropriate for most circumstances. Now, some with exhalation valves, they should not be used in a sterile surgical setting. There are elastomeric respirators without exhalation valves that you could use in these settings. And in all the other settings, you can use the even uncovered exhalation valves, because the CDC has explained in December of 2020 that even uncovered exhalation valves provide better source control than surgical masks. And the simple addition of surgical tape on the valve or a surgical mask over the valve can provide the same source control as a non-valved respirator.
Okay, thank you. That's all I have. Amy, did you have any questions for the witness?
No, I don't have any questions. Thank you.
Your Honor, that concludes OSHA's questions for Mr. Smit.
All right, thank you, Mr. O'Connor. It appears that we have one hand raised from an attendee. And for those on the phone, *3 would be the way to raise your hand. Would Ms. Thompson, would you please promote Rebecca Reindell to panelists so she may ask her question of the witness?
She has been promoted.
All right. Ms. Reindell, please identify yourself and your affiliation, and you may ask your question of the witness.
Thank you, Your Honor. Rebecca Reindell with the AFL-CIO. Thank you for your testimony. Nicholas, I just had a quick question, which was, if an OSHA standard, clearly laid out who has to wear respiratory protection in the standard, and it covers, more folks than who were covered in the ETS. Wondering from your perspective, from the manufacturing side, if the manufacturers would be able to meet the demand. We've heard a lot over the last couple of years that we cannot meet the demand if everybody has to wear respirators. So just wanted to hear a little bit more from your perspective on that. Thank you.
So AMA was actually formed at the end of February of 2021. And when we formed AMA, there was over 51 manufacturers, and we wrote an open letter to the CDC and the US government with our monthly production capacity and what we had currently available at the time in our warehouses. And that's why the FDA and the US government declared the PPE shortage over. We manufacturers had tens of millions, of hundreds of millions of N95s available since last year. They're just simply not being used. And if you do want to increase protection for people, if there's not enough N95s and elastomeric respirators, you can get better protections from surgical masks by pairing it with a mask bracer. So studies have shown that if you pair a surgical mask with a mask bracer, it'll give it a tight seal. So the air goes through the surgical mask, which will then have similar protection as an N95.
Thank you, Mr. Smit. So we have an additional question. Would Ms. Thompson, would you please promote Theo Allen to panelists so he may ask his question?
You have been promoted.
Great, thank you. Good afternoon, Mr. Allen. Could you please identify yourself and your affiliation and ask your question of this witness?
There's no affiliation, although I will identify that I have had contact with Mr. Smit, including having previously invited him to some event that I did. My question is that one of the provisions in the ETS, I believe it's paragraph, it's 502F, note 3, note 1 says, for aerosol generating procedures on persons with suspected or confirmed COVID, employers are recommended to select elastomerics or PAPRs instead of filtering face piece respirators. What's your thought on that provision? And I have more for the record.
So elastomeric studies have shown that elastomeric respirators, when healthcare workers perform things like occupational CPR, they don't lose their seal, while N95s can lose their seal 28% of the